Good afternoon, ladies and gentlemen. Welcome to the webinar organized by the European Reference Kidney Network in conjunction with European Society of Pediatric Nephrology. My name is Marianne Silkjaer. I will help you with moderating this webinar today, and it's really my great pleasure to introduce our speakers. And it's a very special webinar today because we will not only have a scientific speaker, Dr. Marina Vivarelli from Rome, but we will also have a patient's or parent's voice, which will be done by Marianne Silkjaer Nielsen from Denmark. So I will start by introducing Marianne. Marianne is a mother of a girl with MPGN, but she is also a founder of the ComCure Association. So over the past 20 years, Marianne held several executive and senior leadership positions at various pharmaceutical companies, and it's really very instrumental in the ComCure registry, and she works actively together with doctors to find cure for C3 glomerulopathy and also for their IC-MPGN. So our speaker, Dr. Marina Vivarelli, I think really doesn't need any introduction, but still I will do it. Marina completed her training in pediatrics in the University of Pavia in Italy, and then she did the research fellowship at Harvard University Children's Hospital in Boston to study murine B-cell function. In 2006, she joined the Division of Pediatric Nephrology of the Bambino Gesù Children's Hospital in Rome, and since then she works to establish translational research in pediatric immune-mediated renal diseases, and we all know Marina for her work in nephrotic syndrome, on complement-mediated renal diseases, and many other disorders. Since 2023, Marina has the Laboratory of Nephrology and the Clinical Trial Center of the Bambino Gesù Children's Hospital. She co-chairs the European Rare Kidney Disease Network Working Group on TMA and its registry, is a fellow of European Society of Pediatric Nephrology, and she's on the advisory board of ERA. She's also a member of the editorial board of Kidney International and Janssen. She has chaired several guidelines, and so Marina, we are very happy that you found time to present at the webinar today, and now I give the word to you and to Marianne, and we are looking forward to hear your webinar.
Thank you, Elena. Thank you so much for your introduction. And it's really a great pleasure for me to give this webinar today together with Marianne. I think it's always special when we can speak together with our patients and caregivers and try to give a fuller picture of what diseases really are from both points of view. So this webinar is entitled C3G and IC-MPGN, an update. And it's going to start with a video that Marianne has prepared. Okay, so after that, it's difficult to follow, but I'm going to try to give you an update on what we know about these diseases. So when we're talking, you can see my screen now.
Yes.
Perfect. So when we're talking about disease definition and classification, we have to go back to the olden times, before 2007. We know that historically, membranoproliferative GN was a difficult to diagnose and often idiopathic form of glomerular disease, which was characterized and defined based on the location of deposits. If these deposits were subendothelial, it was defined as type 1. If they were subendothelial and subepithelial, it was defined as type 3, and the deposits were more low density. And then there was the infamous type 2 MPGN, where the deposits were intramembranous, as you can see here with the red asterisk, and extremely high density. This disease was called dense deposit disease, and already many decades ago, wonderful study made by different experts in complement had shown that these deposits were due to complement alternative pathway dysregulation. They were indeed made of complement proteins, and this was considered an extremely rare and difficult to treat form of membranoproliferative glomerulonephritis, with a quite bleak outcome and a high risk of recurrence post-transplantation. Subsequently, in 2007, this seminal paper was published by Aude Servet and Fadi Fakouri's group. In this paper, the authors described a new entity. They described 19 patients that had a proliferative glomerulonephritis where there were no dense intramembranous deposits like DDD. There were isolated C3 deposits, but they weren't intramembranous. However, these patients had evidence of complement dysregulation, either because they had autoantibodies that dysregulate the alternative pathway like C3NF, or because they had pathogenic variants in genes that regulate the alternative pathway of complement. This really pointed in the new direction of indicating that there was a wider spectrum of proliferative forms of glomerulonephritis in which there could be a role for the alternative pathway of complement being dysregulated. And moving forward, we defined this entity as C3 glomerulopathy, and we subdivided it into DDD, the entity that we had previously called membranoproliferative type 2 glomerulonephritis, and C3GN, in which the deposits are not intramembranous, but rather subepithelial, mesangial, sometimes subendothelial, but that's quite rare, and in which there can be subepithelial deposits like this white arrow that create humps, which up to that moment had been considered pathognomonic of acute post-infectious GN, but in reality were also seen in these chronic forms of glomerulonephritis. So important studies performed by Sanjeev Sethi at the Mayo Clinic showed that putting together these two diseases, DDD and C3GN, into a same category of C3 glomerulopathy is indeed correct. Because if we laser microdissect glomeruli from these two conditions and look at their proteomic profile, it is substantially identical or very similar, and it is vastly comprised of different complement proteins of the alternative and terminal pathway, and of some of the complement factor H-related proteins, which are regulators. So we now know that by light microscopy, the appearance of these different forms of proliferative glomerulonephritis can be varied. You can have mesangial proliferation, membranoproliferative GN, or diffuse endocapillary proliferation. But the unique feature that makes these common is the intense deposition of C3 by immunofluorescence, which also is then mirrored by what we see by electron microscopy. However, as our understanding went forward, things became even more complex. First of all, we understood that what we see in light microscopy probably represents a continuum. It depends at what time of the disease you perform the biopsy. So you will see a mesangial proliferation in a very initial acute condition, and you will see it moving more towards MPGN as the disease has a longer time to progress. Also, the distinction of considering the alternative pathway dysregulation for these primary GNs only if you have very intense C3 staining has also been put into discussion by data. And I will show you some examples taken from our patient population, but there have been many papers showing this. This is a little girl that came to us at the age of 15 for an acute nephritic syndrome with also nephrotic range proteinuria. She had low C3, slightly reduced C4, which then subsequently normalized, and she had no signs of systemic disease or positive ANA, so she didn't have lupus. However, her biopsy was a biopsy with a so-called full house immunofluorescence with at least equivalent positivity of C3 and IgG. We treated her with conventional immunosuppression, but her response was not optimal. Therefore, after about 6 months, we rebiopsied her. And on the second biopsy, after having had immunosuppression, she clearly had a predominance of C3 with really very little positivity of any other immunoglobulin or complement component. This child had, therefore, a form of of C3 glomerulopathy, which is called an IC-MPGN, in which the IG deposition, initially at least, probably because of an infectious trigger activating the classical pathway, can be just as intense as C3. And this is seen especially in children. She had, however, signs of alternative pathway dysregulation shown by both positivity of a C3NF and a pathogenic variant in the gene for MCP. She also had persistently low circulating C3 and persistently high circulating elevated C5b through 9. At the opposite end of the spectrum, and I need to stress that this is particularly unusual, a few years later, we saw a child, a boy this time, presenting at about 9 years of age with a classic dense deposit disease, so a variant of C3 glomerulopathy with the nephrotic syndrome at onset, the intense and exclusive positivity of C3 by immunofluorescence, and the dense deposits by electron microscopy. This child, again, had positive C3 neph, so an autoantibody dysregulating the alternative pathway, no mutations, normal C5b through 9, and persistently low C3. This child was then rebiopsied about a year and a half later because of a recurrence of his condition. And this time, he had had an infectious trigger. He had a clear, full house immunofluorescence with intense positivity of different complement components and also of IgG. Again, indicating that there is a spectrum here in which the C3 dominance is not always exclusive. This was also recognized in the more recent classifications of this condition, where under the umbrella term of C3 glomerulopathy, there is DDD and C3GN distinguished by electron microscopy, but we also insert the IC-MPGNs. And this has been confirmed by many studies in which the frequency of genetic variants and of circulating autoantibodies is regulating the alternative pathway is found in similar percentages in these same conditions. So C3 deposition in these forms is often predominant, but it is not by all means exclusive. So what causes these conditions? So we know that there are different components that can be both circulating antibodies, and also mutations or pathogenic variants in complement regulator genes, and also in complement factors that can determine an abnormal C3 convertase activity. The C3 convertase, if it's not correctly regulated and is hyperactivated, will give rise to reduced levels of C3 in the circulation because the C3 convertase is continually active, and to deposition of C3 and of the subsequent components of the alternative and terminal pathway in the glomeruli of the kidneys, giving rise to what we have seen by immunofluorescence. So when you have a bioptic diagnosis of C3G or IC-MPGN, so an MPGN in which you have excluded all the secondary causes, paraproteins, autoimmune diseases, and infections, what you need to do is both a serological and a genetic screening looking for the dysregulation of the alternative pathway of complement. And this is done by looking at these genes, by dosing complement components and regulators in the circulation, by dosing complement breakdown and split products, again in the circulation, and by dosing autoantibodies. And this way you can find patterns of dysregulation in the alternative pathway of complement, in which you can see an increased C3 convertase turnover, which is perhaps more likely in DDD compared to C3GN, or an increased C5 turnover, which is perhaps more likely in C3GN compared to DDD. And as we move forward and our understanding of the underlying point in which the alternative pathway is dysregulated becomes better, clearly we will be able to pinpoint therapy in the moment in which we have different complement inhibitors more clearly. So an example of how this can be important came from this important paper published by the Bergamo group and Jason in 2017. They took a vast cohort of patients with different forms of these conditions, 173, about half with IC-MPGN and half with C3G, in which they did an unbiased analysis called a cluster analysis, looking at 34 different features: clinical, histologic, serologic, and genetic, and identifying 4 clusters that had similar features among each other. The distinction of the different clusters has then been validated subsequently also in other publications and has been shown to be pathophysiologically relevant and also relevant in terms of outcome. In particular, the first 3 groups have more active disease, whereas cluster 4 tends to be a more chronic and more scarcely responsive to treatment dysregulation, in which the dysregulation of the alternative pathway is more pronounced in the solid phase. Another important new element has been the value of genetic screening. So the British group published in JASN in 2020 this paper in which they took 165 patients with different forms of primary membranoproliferative GN, and they looked for rare variants of the main genes that have been involved in complement dysregulation and also at DGKE, which is in reality a cause of atypical HUS, so slightly different. But what they found was that giving a very stringent definition of rare variant, because they used a minor allele frequency that was extremely, extremely low, below 0.0001, they didn't find any difference in the number of variants that they found in this population of 165 patients compared to over 10,000 healthy controls. This is an important point because when you're using such a low minor allele frequency, you're considering the range of ultra rare alleles that are causing Mendelian disease. And you're really saying that this is not a Mendelian disease. So it's not a disease in which the correlation between genotype and phenotype is clear cut, and this is a monogenic condition. We know that there are extremely rare forms of C3 glomerulopathy and IC-MPGN that are monogenic, and I'm going to mention some subsequently, but the vast majority are not. However, when we give a different cutoff of a minor allele frequency and we talk about so-called rare variants, which in reality are relatively common variants that can be implicated in complex traits and therefore which implicate a role of genetics that is a co-element in determining the pathogenesis of a disease that then requires second hits and different triggers, and in which there can be also a coexistence of an autoantibody, for example, we find a much higher frequency of pathogenic variants in complement factor H, factor I, C3, or complement factor B. And I wanted to mention the paper that was published by the French group in CJASN in 2023, because it showed us the importance of genetic screening when we give this type of a definition of a rare variant. This group looked at 398 patients and found rare variants in 17% of these in complement factor H, factor I, or C3. If we look at the ages, this is important because it makes us think of when to screen our patients. They found these rare variants in patients at all ages, going even into the 70s and 80s. But more importantly, they found that these pathogenic variants had a correlation with quantitative complement protein deficiency. So they had a biological effect. Here you see the complement factor H pathogenic variants showing lower C3 circulating values, significantly lower, and the C3 pathogenic variants having significantly lower C3 circulating values. They also showed that the complement factor H pathogenic variants had lower circulating factor H, and that the complement factor I pathogenic variants had highly significantly lower factor I circulating values. So these appear to be variants that have a pathogenic effect. They also show that these variants had a functional impact on outcome, and that the patients that did not present a variant had a significantly better kidney survival over 240 months compared to the others, in particular with the C3 and complement factor I variants having a particularly worse outcome. So overall, I think this really indicates how we need to think about the value of genetic screening moving forward. So in terms of clinical features, what are the presenting symptoms of these conditions? They are very heterogeneous. So C3G and IC-MPGN can present with macroscopic hematuria, which can be either intra-infectious or post-infectious. When it is intra-infectious, so we have a macrohematuria kind of presenting like a child with IgA nephropathy, this implicates often one of the classic monogenic forms of this disease, which was first described by Professor Daniel Gale in The Lancet in 2010. And these are patients that were initially of Cypriot origin only and then and others were identified as well, that have pathogenic mutations in factor H-related protein 5. And they have a picture which is really similar to an IgA nephropathy with the intrainfectious hematuria and a quite difficult outcome and prognosis. Another picture that we can have is the post-infectious macrohematuria, like in post-infectious GN that we see frequently in children. These patients will have, however, features that need to make you think about C3G if the low C3 that is typical of post-infectious persists for more than 12 weeks, or if the recurrency of the macrohematuria persists for more than 12 weeks. And in an important paper that was published by Sanjeev Sethi in 2012, they went back to look at their adults with post-infectious. And in 11 of these patients that had had a chronic course of the disease, they found either C3nef positivity or mutations in different genes involved in the alternative pathway of dysregulation, indicating that these forms are atypical post-infectious GN, which in reality represent part of the spectrum of C3 glomerulopathy. These conditions can also present by accidental finding with low-grade proteinuria with microhematuria or with nephrotic syndrome, and these tend to be the more severe forms, or, and there's been a flurry of papers in the last 4 or 5 years describing these forms, there can be patients that present with a spectrum in which there is a coexistence of features of atypical HUS and of C3G, really pointing to the fact that these are two diseases that are part of the same family. We also need to remember that since the dysregulation is circulating, you can have extrarenal features. So you need to look for partial lipodystrophy. It can be quite subtle. And you need to look for deposits of C3 in the retina called drusen, which in the very long term can give some blind spots. In terms of management, so when we're thinking about these diseases, we know that upstream there's a dysregulation of the alternative pathway of complement. And this is liberating C5a and C3a, which are anaphylatoxins. So at the glomerular level, what you're getting is inflammation, monocytes, neutrophils, and mesangial proliferation. So in the absence of adequate targeted therapy, what you do is this. You perform a biopsy that gives you the diagnosis. You perform a workup of the alternative pathway of complement, and you start supportive therapy, including RAS blockade, low-salt diet, and lipid control. And then you look at your proteinuria. If the proteinuria is significant but non-nephrotic, and you have moderate inflammation on the biopsy, you can consider immunosuppression with prednisone plus or minus mycophenolate. You definitely need to use methylprednisolone boluses plus prednisone and mycophenolate if the proteinuria is in the nephrotic range. And then, or if you have severe inflammation on the biopsy or a reduced eGFR. And then you reassess. If you've had a complete remission after 6 to 9 months, you taper the prednisone and you continue the mycophenolate. If not, you consider therapy with complement blockers. And in this, we have made major progress in the last few years. So the challenges and unsolved issues remain minimizing toxicity while controlling proteinuria, preserving kidney function, tailoring therapy, and optimizing quality of life. And in terms of this, the main novelty that we have is a more vast range of complement inhibitors that are coming through the pipeline and that are currently being evaluated in these conditions. So again, when we're thinking about what's happening in our patients, at a glomerular level, there's inflammation. But obviously, if we could go to the origin of that inflammation and actually shut off the underlying pathophysiology, we obviously would be using a targeted disease that could be a targeted therapy that could be disease modifying. And this is obviously advantageous from a variety of points of view. So historically, the only complement inhibitor that we had was eculizumab, a monoclonal antibody that blocks C5. This was initially used many, many years ago by our group in a child with DDD. And in his case, it was spectacularly effective, both in reducing proteinuria and in improving the glomerular lesions. However, we know that this treatment is very expensive, it's IV, and it carries a risk of meningococcal inflammation. But not only, we also know that subsequently, when this drug was used and studied in a more rigorous fashion, it was in reality rather disappointing because it only overall brought about partial remission in about 30% of cases. And this is shown in this prospective study, the only prospective study to date, and also in a variety of larger retrospective studies. However, fortunately, we now have many other targets that we can consider. And I put in blue here the targets that are actually oral agents, and in red, a target of C3, which is instead an agent that we can give sub-Q, just to show you that we have many different options. One of them, avacopan, is still addressing the terminal pathway of complement. The others are addressing the C3 convertase, so more upstream at the crux of the alternative pathway of complement dysregulation. So briefly, I'll run through the new complement inhibitors that we have and the results that we have. So first of all, danicopan. Danicopan is an oral agent that has targeted factor D. I put it in gray because in reality, the phase 2 studies were not positive. The results that we obtained were not positive. And what these studies taught us, which has been really important moving forward to design more effective factor D inhibitors, which will be coming through the pipeline in the next few months or years, is that when you're inhibiting factor D, it's not a progressive curve. It's an all or nothing. So either you can bring the level of factor D down to 0, or you don't see a biological effect. And this clearly makes the pharmacokinetic of the drug a little bit more challenging. When you're targeting instead factor B, as the drug iptacopan does, we have an inhibitor which is again given per mouth, and that is arriving into phase 2 and also into phase 3 studies. And I put the studies in red because they are also addressing adolescents, 12 to 18-year-olds, both for C3 glomerulopathy and now with a newly opening study for IC-MPGN. We also have 2 drugs targeting C3. One of them, pegcetacoplan, I put in dark black because it's reached the phase 3 phase, and it is enrolling both adults and adolescents. And the other one, ROC3, is much more initial. It's a small interfering RNA which inhibits the synthesis in the liver of C3, and it's just starting out now in a phase 1/2A. We then have avacopan, which I mentioned earlier, which blocks the C5a receptor. The phase 2 trial has been completed, and I'll mention the results in my next slide, and it also enrolled adolescents. And then we have 3 new kids on the block. KP104 is an IV agent blocking both C3b and C5, which is in a phase 2 trial for both IgA nephropathy and C3G, unfortunately only for adults. Then we have NM8074 blocking BB, which is also in a phase 1b/2a for C3G, just opened. And then we have an inhibitor of the lectin pathway, OMS906, which is just starting to enroll in a phase 2 study addressing both C3G and IC-MPGN. So you see that there are a lot of agents coming through the pipeline to address these diseases. In terms of results, I'm going to show you only the results of phase 2 and phase 3 trials. So for avacopan, the C5a receptor drug, the phase 2 trial is completed. The results are available. Unfortunately, this drug did not meet its primary endpoint, which was a very ambitious endpoint because it was a histologic endpoint. However, it did show reduction of proteinuria in most of the patients in which it was treated. It was given, and I am not aware whether or not it is being developed in a phase 3. Iptacopan, we have results from the phase 2 trials, which looked at small groups of patients, both on native and on transplanted kidney. And the primary endpoint was met in both cohorts. In cohort A, it was in terms of proteinuria. In cohort B, it was in terms of reduction of C3 deposit compared to baseline. And it also showed biological activity with sustained normalization of circulating C3. The phase 3 study is completed, and the interim results have been announced by the company, but had not been published yet, but they have met their primary endpoint in terms of proteinuria reduction. For pegcetacoplan, the agent which is administered sub-Q and which blocks C3, the phase 2 study met its primary endpoint in terms of proteinuria reduction. The phase 3 study is completed and no results have been announced yet, but they are very briefly coming. We can imagine from the fact that this study has already been closed in terms of enrollment. So in conclusion, we really are better off than 50 years ago in terms of prognosis and therapeutic options. There probably will not be a single therapeutic agent that will work in all patients because this is a very heterogeneous condition. And this is why, given the rarity and the heterogeneity, we really need collaborative efforts for pathogenesis and for prospective studies. And this brings me to the next part of our talk. I will briefly talk and then give the floor to Marianne. So through the patient organization CompCure, in collaboration with the ERK registry, a sub-registry specifically addressing these diseases has been created. This is a cohort study to which both incident and prevalent patients of all ages with both C3G and IC-MPGN can be enrolled. It is a sub-registry of the ERKREG, and there is a compensation for centers that can both do initial enrollment and annual updates, which is given by CompCure. And the other wonderful thing about this is that it also comprises the possibility for standardized immunodiagnostics and genetic testing, which can, in countries where one of the laboratories of excellency which has been identified, which are in different European countries, if the country of the patient is in that country, the cost will be charged to their national health system. Otherwise, the cost will be charged to CompCure. There's also an archive of biopsies, and anyone interested in enrolling patients into this sub-registry should contact Johanna Sladowska, who I thank for preparing these slides. And now I hand it over to Marianne Silkjaer Nielsen, who will talk to you about CompCure. Thank you, Marianne.
Thank you very much, Marina, and thank you for the opportunity to come here and introduce or give an update on CompCure. So for those of you who do not know CompCure yet, it's a non-for-profit association and it is registered with the Danish authorities. We can go to the next slide. So the objectives of CompCure were defined by our steering committee, and that is consisting of leading experts from all over Europe. The most important objective is to improve the long-term outcome for patients living with IC-MPGN or C3G. We want to do this by creating better evidence, and this is what Marina just talked about. Here, our registry is absolutely critical. We also want to make sure that there is more awareness about these diseases. So we are actually undertaking quite a lot of activities to do that, and I'm happy to talk about that later in the presentation. Finally, we want to develop a platform that is actually hopefully supporting our opportunity to address the unmet medical needs in rare diseases more broadly. We can go to the next slide. So in order to deliver on our objectives in the most effective way, we find it's very important to hear the patient's voices and to listen to their needs. And based on this, we have defined, or we are building now, a patient and caregiver board. This board right now consists of 9 participants from 8 different countries. Most of these members are actually leading national patient organizations, and that gives them a very good opportunity to, in a representative way, give input and inform our strategy and target setting, and also to give input on the findings that will be developed with CompCure, and of course also to communicate our learnings locally in their specific countries. We can go to the next slide. So we already learned a lot from these patients and caregivers, actually their needs are pretty common. So a lot of them are very concerned about complications and outcome. We know that the outcome, the long-term outcome in these diseases is bleak, and this is what a lot of people are worrying about, and that is actually a huge stress factor to manage people. They are insecure about how to manage their disease, and they don't feel that there is enough knowledge about how to actually manage the disease. They dream about a therapy, and we are very excited about all the therapies that are in development, especially those in late-stage development. Here I'm getting a specific request or ask from people with IC-MPGN, like my daughter. a lot of them are actually a little bit concerned. There are a lot of great things happening in C3G faster, but please do not forget about IC-MPGN. If you have patients that fits the inclusion criteria of some of the trials, please think about enrolling them. Some of the patients would also have liked to be early diagnosed. Maybe they feel that they actually, something was wrong with them for a long time, or their kids, but it took maybe years to actually get sick enough to get to a hospital, or to a very good hospital that could help making the diagnosis. So anything that could accelerate the time from the early manifestations till diagnosis is something that the patients would see very valuable. And that brings me to the next topic on the next slide, and that regards awareness. It's difficult to diagnose a disease that you're not aware of, and that's why we believe that awareness is very, very important. And we have undertaken quite a lot of activities to drive awareness, both in C3G and IC-MPGN. And just in 2024, we actually reached more than 4 million people. If you're interested in learning more about our activities, you are very welcome to follow us either on LinkedIn, or look at our homepage, or whatever channels that you like. We are pretty consistently giving updates. So we can go to the next slide. And based on all of this information that we have been sharing, also with patients, we are getting a lot of requests from patients who would like to join ComCure and be part of the registry. But it's not always possible for them. So we hope that you will help making it possible for them to join the ComCure registry. And I just want to thank you for this and for the time.
Thank you, Marianne. And with this, I put the slide for the next webinars. There's so much going on. So there's two webinars in April. Dieter Hafner will be talking about rickets in children and adults on April 9th, and then Matt Bolz-Jonsson will be talking about patient involvement in guidelines on April 22nd. In May, we have Johan van de Walle doing frequently asked questions on TMA on May 7th, and Ralph Hilgers giving an overview of biostatistical approaches in clinical research of rare diseases on May 14th. And with that, I think we can pass it on to questions, which are always the best part of these webinars.
Thank you very much, Marianne and Marina. It was a wonderful webinar, and I think the story of Marianne in the beginnings was really impactful. Then it somehow set up the stage, and then to let us all realize what we are working for, really for treating this very challenging disease. So thank you so much. And Marina, thanks a lot. You get a lot of compliments in the chat and in the questions, so it was a wonderful webinar. But now, the exciting part of the questions. So the questions are coming, and please just continue typing them, and then I will try to classify them a little bit in different categories. So maybe to start with pathogens, several people ask about the pathogenesis of complement deposition and low C3 in the circulation. So the specific question is about the low C3 in the circulation, whether it's due to the deposition or due to the decreased production. I think you can easily answer that one.
Yeah, so it's thought to be due to the fact that you're using it up. So it's not that you're producing less, but rather that the C3 convertase is continually activated and that it's not being shut off. And in reality, it's important to keep in mind, I've given you quite a pediatric perspective. When we talk about it with our adult nephrology colleagues, it is less ubiquitous to have low circulating C3 levels in patients that are adults with C3 glomerulopathy. It is still the majority, but it's much less frequent. Whereas, at least in my experience and most colleagues, when I talk about it with pediatric experience, it's extremely exceptional to not have low or very low C3 levels. In adults, there is about a 40% population that has normal circulating C3. But the idea is that, you know, you're consuming the C3, so you're finding it less, and you're finding it instead deposited in the kidney within those deposits that are beautifully represented in the electron microscopy figures. And perhaps the fact that the circulating levels are less intensely low in adults just points to the fact that it's a probably more chronic and less active form of disease. And also we measure different breakdown products and different parts of the pathway to try to see, for example, looking at circulating C5b through 9, so the membrane attack complex, so the terminal pathway, if there is more of a C5 convertase versus C3 convertase dysregulation. And this is something in which fine-tuning and setting more patients is super important to try to create clusters, as I was showing you, and to fingerprint these patients more, so that as we have more complement inhibitors available, we can make an educated guess and say, with this profile for this patient, perhaps treating him here at this point of the pathway can be more effective. For this other patient with this complement profile, perhaps treating him there can be more effective. That's really our final objective. And that's why, you know, also collecting more samples and having more information, even from the trials, about the biomarkers is going to be super important.
Well, very, very interesting, Marina. So there is another question regarding the pathogenesis and disease activity monitoring. So could there be a correlation with the disease activity or recovery from the disease activity and the changes in the complement level? So can you use complement to monitor the disease activity?
Yeah, so that's a really good point. So obviously if you have normal C3 from the beginning, then it's not possible. But normally what we see is that in patients who are doing really well, at a certain point, you see that the C3 levels normalize. However, you can have a patient that goes into remission in terms of proteinuria and kidney function and looks great from that point of view, but still has persistently low C3. And, you know, that is an indication that something is cooking and that you haven't been able to shut off. So when you're using the new complement inhibitors that target the C3 convertase, all of them, what you're seeing is that the C3 levels that were low initially are normalizing or even becoming higher than normal. And that really gives you the impression that you're doing something to the underlying pathogenesis, which you're not doing when you're giving RAS blockade or prednisone or mycophenolate. And so obviously if it is low and then it normalizes either spontaneously or with treatment, then you really have the impression that you're doing something that is probably going to reduce those deposits. And that's a game changer, I think.
Okay, and would you monitor C3 levels, for example, in patients in remission? And does it tell something when you see again complement activation? Because sometimes you don't really initially see some changes in your analysis of kidney function.
I mean, I don't think it's a validated prognostic marker with correlated to outcome, but in general, from what we know of the pathophysiology, I would consider it more reassuring to have normalized C3 than not. But I don't think the data is out there, and it's never actually been shown to correlate with outcome, largely because also in the adult populations, it can be normal. And so obviously that makes the numbers look a lot different.
Okay, thank you, Marina. Then we have several questions regarding treatment. So one of the questions is what would be your preferred treatment for patients with rapidly progressive manifestations like regressions on the biopsy, AKI?
So that's a really good point. I'm sorry I didn't have time to mention that, but those are particularly aggressive forms. So pretty much all forms, irrespective of the underlying pathophysiology, that have a rapidly progressive phenotype. So they have crescents on the kidney biopsy, sometimes necrosis, and a rapid and acute decrease in their kidney function, need to be treated with very aggressive antiproliferative agents. So high dose methylprednisolone and often cyclophosphamide. And this is irrespective of the underlying disease. This kind of representation can be present in C3G, IC-MPGN, IgA nephropathy, different forms of vasculitis. But when we see the crescents, the necrosis, and the rapidly reduction in the serum creatinine, with the patient becoming rapidly, rapidly, I'm saying days, progressing towards the need for dialysis, we need to hit hard and we need to hit right away. And this can occasionally happen also with acute post-infectious forms. So that's an important caveat. I'm sorry for omitting this. All of those forms need to be treated with anti-proliferative agents and all at the same time.
Okay, so yeah, the question is whether you can use plasma exchange or rituximab in some of these diseases. So yeah.
Okay, so those are good questions also. So in terms of plasmapheresis, conceptually, it should work because you're eliminating whatever is dysregulating the alternative pathway of complement, most likely. In reality, the results with plasmapheresis have been rather disappointing. These are quite old results, probably due to the fact that it's really difficult to be that effective with plasmapheresis to actually be able to override the underlying dysregulation. And so I think I would probably not recommend the use of plasmapheresis in common routine practice in the vast majority of patients. In terms of the use of an anti-CD20 monoclonal antibody, such as rituximab, in theory, it would make sense to use it if you have evidence of circulating antibodies, autoantibodies that are dysregulating the alternative pathway of complement. And this is the reason for why it has been attempted. In reality, the results with anti-CD20 have been overall very disappointing. The reason for this is probably, like the factor D inhibition, is that it's an all or nothing effect. So reducing the levels of the autoantibodies, as you can imagine to perform using an anti-CD20 monoclonal antibody, is not going to really change the dysregulation of the alternative pathway. You would have to bring those antibody levels down to 0, and that is not achievable with an anti-CD20. Therefore, in the vast majority of cases, I would not recommend using an anti-CD20, and in the literature, it has not shown to be an effective form of treatment for these forms of proliferative glomerulonephritis.
Okay, that's clear, Marina. So then there are several people asking about steroid-sparing regimens. So one of the questions, would MMF in some patients would be enough to reduce proteinuria without steroids?
I don't know, in the sense that we don't have any evidence about that. Normally, at least a short cycle of prednisone at the beginning is given in together with MMF. So in other words, if the proteinuria and the kidney biopsy are florid enough to justify using immunosuppression, to the best of my knowledge, at least a short course in the beginning of prednisone is essentially always given. So we really don't have the data to say if MMF alone can be effective. Certainly, MMF has been proven, especially by the works performed by the Glosen Spanish group led by Caravaca Fontan, to be more effective than other types of immunosuppression, for example, calcineurin inhibitors. And in the last paper that this group published, MMF was actually superior also to eculizumab. So we're all excited about the new complement inhibitors, but I must also underline that a lot of patients with prednisone that you try to taper as fast as possible, and you normally can get rid of it in about 6 months in most patients, and mycophenolate given for a longer period of time, many patients do actually very well. As we move forward, though, having these different options and having the fact that they can actually act at the level of the true underlying pathophysiology is obviously going to be advantageous. But these are also results that we need to have confirmed, and the trial results are still very, very preliminary.
Okay, very clear. Some other people are asking, there is another question, actually, a couple of questions regarding whether do you think that this new complement inhibiting drugs at a certain moment would replace other immunosuppressive drugs? Or
So that's what we hope. We hope that the data from the phase 3 trials will be good enough that we will be able, probably in the relatively near future, to say, okay, I feel comfortable first line when I have a new patient coming in with a new onset of using a complement inhibitor because the data looks really good. But we just don't have enough information now. But that's obviously, our goal, to be able to do something that is targeted.
Right. Yeah, so then the other question is, let me see, because they're quite small here. Yeah, so it's more or less a similar question. So whether you would use anti-complement drugs in patients with subnephrotic proteinuria with milder diseases, whether do you think that they can be beneficial without steroids? So,
so the trials were designed with a cutoff of proteinuria that was of 1 gram, and a nice and I must say quite sort of uplifting thing was that all the companies for all these trials have followed a very similar trial design, which is actually going to be really important when retrospectively we're trying to sort of do a meta-analysis of all of these agents, and pretty pretty consistently, the cutoff has been given as 1 gram per day or a UPCR of 1. This is obviously not a nephrotic range proteinuria, and this is recognizing the fact that we know that proteinuria is in the long term going to create fibrosis and chronic damage, even if it's not in the nephrotic range, so that we can't rest until the proteinuria is completely negative. And in the moment in which we know that these agents are safe and effective, yeah, I think we will use them also in subnephrotic. Obviously, if you have an extremely low, like less than 500 milligrams per day level of proteinuria, and you can give some RAS blockade and get rid of it, then perhaps I would be less enthusiastic, even though we don't really know what, having the low circulating C3 with the C3 depositing in the kidney, we're not really confident whether or not that in the long term in itself is damaging. We just don't have enough information right now.
Right. Marina, I think many people who are listening to the webinar do not have an access to genetic diagnosis or to their immunological tests. So, what do you recommend for those people? How can they contribute to the registry? Maybe whether there is access for genetics or immunological tests for people who don't have it in their country?
Yes, I think Marianne can answer this one.
Yes, I can do that. So I think this is one of the advantages with CompCure, that we actually support people on getting all of these important analysis done. And these are being done by the reference labs that we have, which are really, the best and most experienced labs that are in Europe.
Mm-hmm. So this means that people who have access to the registry, who contribute to the registry, they get immediately an access to the genetic diagnosis and the immunological diagnosis. Is it right? Yeah, I think this is a very important message, and this is a very important message to everybody who is listening, because if you have a patient where you have C3G on the biopsy, and then you can probably write to Marina or Marianne and contribute to the registry and get access to this test. So this is very, very nice. So Marina, I have a question on my behalf. All the studies so far, they are done with in adults. There are a few in adolescents. How do you see the studies going to children? Are there plans, at least for some drugs for the pediatric?
So that's a really good point. So in reality, in general, that there's a huge problem in pushing forward the trials into enrolling at least adolescents right from the beginning. So in reality, in this niche, there has been a big effort by the pharmaceutical companies to actually do this. The Avacopan trial enrolled also adolescents, 12 to 18-year-olds. So we have the data also in a few, a small number of adolescents. But for example, we had treated one patient and she responded. Both the Iptacopan trials are now enrolling both through C3G and for IC-MPGN, also 12 to 18-year-olds. The pegcetacoplan trial, so the C3 blocker, is also enrolling 12 to 18. So for all of these, we will obtain data in the adolescent population. Pushing it further down will require the safety data to come through and to be reassuring, but there is definitely an appreciation of how this is a condition that affects pediatric patients very importantly, and also that this is the window of opportunity in which the patient has the highest chance to be a good responder. So I'm pretty confident that as the safety data rolls through, if it is reassuring, the health authorities will allow these trials to be pushed into the younger population, and that there will be an effort to do this. So let's hope, but that's definitely the general plan, I hope.
Yeah, let's cross the fingers, and I think in the meantime it's very important that people include their patients in the registries, that we have experts who can answer questions regarding this very difficult and rare condition, and hopefully the companies will, be eager to perform trials in children so that children can get access to the new treatments. So I'm looking through the question pools. I think we asked and answered most of the questions. Yeah, I think our time is over, and I would like to thank you both again for the wonderful webinar, for the excellent discussion, and see you again in some time. Bye-bye, everybody. Thanks a lot, and join ERKNet webinars in the future. Bye-bye.
Thank you.
Thank you. Bye.